Disease and the body organs. There are times when a particular organ develops a disease and then the organ eventually fails. Those who have liver disease can later develop liver failure. Those who have kidney disease can develop kidney failure. And such is the case with those who develop cardiomyopathy, as they can have a disease of just the heart and then eventually will lead to heart failure. But what are those causes, say, of liver failure, hepatitis? What are those causes of kidney disease? Maybe polycystic kidney disease? Well then, what are the causes of cardiomyopathy that can lead to heart failure? So glad you asked, because that information is in our next slide. Cardiomyopathy is fancy for disease of the heart muscle. There are 4 main types of cardiomyopathy. The most prevalent type is dilated cardiomyopathy. I actually have it highlighted here in green. The cause of dilated cardiomyopathy could include alcohol abuse, chemotherapy, infection. This is actually strep that you're seeing here. And do you know why we want to catch strep so early? Because the strep bacteria loves to go to the heart and cause disease if it can. Well, actually, the patient can develop rheumatic fever or rheumatic disease. Okay. Poor nutrition. Use of cocaine and amphetamines, and or use of anabolic steroids, such as what that person is injecting into their muscle right there. Last but not least, pregnancy. All of the pictures here and things discussed can cause dilated cardiomyopathy. It can also be caused by heart attacks. I forgot to include that. But do take a look at this picture. And in dilated cardiomyopathy, the wall thickness are actually considered normal, but the ventricles are actually too big and they're flabby-like, and therefore they have decreased cardiac output. Well, what does decreased cardiac output look like? It's pretty much what heart failure looks like. It's dyspnea on exertion, decreased exercise capacity, fatigue, palpitations, and so forth. The next type of cardiomyopathy is hypertrophic cardiomyopathy, or as we say in the hospital, HCM. In HCM, the heart muscle hypertrophies and stiffens with use. Just like our athletes who exercise and by default their muscles grow and enlarge, so does the heart. However, this isn't a good thing. In fact, speaking of athletes, this type of disease seems to only affect athletes, so you would think. But truthfully, athletes are constantly exercising, thus why we have a bump in occurrences of this condition in athletic persons. Few things to know about HCM is that it is a genetic autosomal dominant condition, so please make sure to focus on family planning. Maybe they need to consider donating a sperm or an egg or consider adopting. People with HCM are asymptomatic until maybe late adolescent or early adulthood. That's when the heart is most likely have outgrown itself, I should say. Now, the first sign or symptom of the disease may actually be sudden death. Do what? Yes. Okay, so let's rewind 3 clicks back to explain the sudden death piece. People with HCM die because the heart has arrhythmias, such as V-tach and V-fib. Oftentimes, the disease is progressing and HCM patients will have bursts of these dysrhythmias during activity, which makes them breathless and dizzy, or maybe pass out and sweat and even have palpitations. Have you yourself ever experienced these feelings when you're exercising? Answer is most definitely yes, if you actually have exercised. So to an athlete, these symptoms feel somewhat like normal sensations, and they will oftentimes write off those feelings to dehydration, maybe to heat, maybe too much intensity, or some other factor. I mean, no one wants to think that their heart is actually growing too big and I should get it checked out because it's malfunctioning. That's just not normal thinking processes. So oftentimes their heart in those situations will convert back to, say, normal sinus rhythm, and thus the athlete doesn't actually seek out medical care because once again, they will attribute it to something like stretching, or maybe they pulled a chest muscle. I don't know. Well, whatever the reason the athlete attributes to their symptoms, they oftentimes don't get help. That being said, some athletes will not convert themselves out of VTAC or VFib, and their life may actually just end right there. That's why we say it's one of the first, oftentimes, signs and symptoms of HCM is death. I would actually like you to watch a 2-minute video I put in the module about a girl who suffers a lethal heart dysrhythmia. And from that video, you are going to learn 2 things that must be done to help a person with HCM who's experiencing a lethal arrhythmia. 2 things, that's it. Watch the video so you will know what those 2 things are. Next. Restrictive cardiomyopathy. This is actually the rarest type of cardiomyopathy. It is caused by a condition called sarcoidosis. That's sarcoidosis. This is where the body develops granulomas in various places of the body, such as the heart, and unfortunately, prognosis is pretty poor for that condition. The other type of cardiomyopathy is arrhythmogenic right ventricular cardiomyopathy. I will say the name's kind of misleading because in 1/3 of the cases, the left side of the heart actually is the one with the problem. However, don't get fixated on that. In this condition, myocardial tissue is actually replaced with fibrous or fatty tissue, and this is a genetic type of heart failure as well. Okay, what are we going to do for our patients who have cardiomyopathy? Well, there's the obvious. If they are on chemo, stop it. If they are drinking excessively, stop it. If they're doing cocaine or anabolic steroids, or maybe if they're pregnant, have the baby and stop the cocaine. Hopefully you're not doing both at once. Moving forward, whatever you need to do to prevent further injury, but obviously you can't change genetics, so let's keep looking at our options. We need to place patients on anti-dysrhythmic medications, and we need to teach them to report palpitations, chest pains, dizziness, or fainting. These are signs that arrhythmias are taking place, and maybe we need to up their medications, or maybe need to give 2 instead of just 1, whatever the case may be. We might even place an AICD inside a patient. That stands for Automated Implantable Cardioverter Defibrillator. It's a mouthful. I'll just keep saying AICD. We're going to place this maybe inside their chest to detect and to shock any lethal rhythms that may occur. Now, our medication management is going to look like for our patients with all types of cardiomyopathy to include a few things. I am going to note some exceptions, but let me just let me note the exceptions first. Yeah, let's do that. Okay, patients who have HCM, they are not allowed to have vasodilators, such as ACE inhibitors or apresilene, which is a type of vasodilator. HCM patients are not allowed to have diuretics, nitrates, or cardiac glycoside, such as like digoxin. Those drugs are good for all other types of cardiomyopathy, but not those for HCM. Oh my gosh, so what do patients with HCM take? All right, good. Well, HCM patients are usually placed on beta blockers, and they're placed on calcium channel blockers. Did you know you didn't have to check anybody's calcium level before giving a calcium channel blocker? Just throwing that out there. Not a test question, but just FYI. Okay, so HCM patients, they can only get 2 types of medications. Everybody else can get the ones I previously mentioned. Right. If surgery is indicated, meaning our person has a very bad ejection fraction because we did an echocardiogram on them, then we are going to look at surgery possibly, such as a ventriculomyomectomy. This is where we're going to take part of the septum, which is the middle of the heart, out due to its obstruction in the ventricle. So we're going to say open up the chamber a little bit by doing this procedure. We can also do a percutaneous alcohol septal ablation. This is where we are going to inject absolute alcohol, and we're going to intentionally infarct that septal branch where it is hypertrophying too much. We're going to kill the inside of the heart. Now, for those who have arrhythmogenic right ventricular cardiomyopathy, we are possibly going to do an ablation with a high-frequency electrical like zap to the area of the heart that keeps throwing arrhythmias. We call that an ablation. All right, we can also do a heart transplant. Right. That is usually from a very generous person. It is the choice of treatment for those who have dilated cardiomyopathy patients. Now, I have heard that it can be considered treatment for those who have HCM. However, it's not very often that is done. And the person must be in stage. We can also do it if somebody has a congenital heart disease, and we can also do a heart transplant if somebody has valvular disease as well. I think it's right about the perfect time to talk more about heart transplants. Ooh. So what is the transplant criteria? Who is going to be eligible for one? Well, they have to have a life expectancy less than 1 year. Right, somebody has to diagnose them to die within 1 year. It's a little scary. They have to be younger than 65 years old. They need to be in stage 3 or stage 4 heart failure. It only goes up to 4. They need to have normal lungs, or if they have abnormal lungs, maybe just slightly altered pulmonary vascular resistance, but otherwise it should be very normal lungs. They need to have no active infections, no UTIs, no, especially not MRSA anywhere, but no pneumonia, no nothing like that. They need to have a stable mental state, because it is going to be for the long haul to take meds and to, really protect themselves from infection and other things and care they have to do. There needs to be no evidence of alcohol abuse or drug abuse. Now, you can proceed with your heart failure because you've met that long list of criteria. What's a very interesting thing is when they actually separate the donor heart and apply it to the recipient's heart, believe it or not, there is actually a little bit left of the SA node on the recipient's heart whenever they dissect it out. So when the donor heart is put on and it is in control of the rhythm, we will actually see 2 P waves on an ECG. This is crazy to me. They will have a little bit of the donor's rhythm and a little bit of the recipient's rhythm trying to show up on the EKG. The recipient's rhythm is not strong enough to actually power and cause issues, but just look for that finding on an EKG and we consider it normal. Don't freak out if you see 2 P waves. Now, because a patient who has a heart transplant has had their vagus nerve cut, which is really closely connected to the heart, that vagus nerve is cut. Therefore, a person, if they were to vagal down, they would not have a drop in heart rate. So if they vagal down, they would not have a drop in heart rate. We actually can use vagaling as a therapeutic procedure for a person who has a fast heart rate. We ask them to bear down and stimulate the vagus nerve like that. And this person is not going to respond to that, very interestingly. Okay, this patient, as they are post-op, needs to make sure to move quite slowly. So if they're going from a lying position to a sitting to a standing, they are going to experience profound orthostatic hypotension. So please move this person slow until their body gets adjusted. Now, what are these blanks here? What will not work on this patient? Let's look at the first thing. Atropine. Atropine is a medication used to increase the heart rate. And because we have been disconnected from the vagus nerve, this medication is going to be like pouring water into their bloodstream. Nothing is going to happen to their heart rate. So if you are, say, in ICU or ER, or maybe you're a CRNA and you want to up somebody's heart rate, remember if they are a heart transplant patient or not, because if they are, don't even bother giving them this drug. Another medication that will not work on this patient is digoxin. It worked before the heart transplant, but now, afterwards, this is also like giving them water. Nothing's going to happen. Last but not least is carotid sinus stimulation. So you may or may not know this, but carotid sinus stimulation means you would actually place your thumbs on somebody's carotids, your thumbs and your forefinger on their carotid, and if they have too high of a heart rate, you can actually stimulate by doing a carotid massage. And usually only a provider can do this, but it's meant and intended to send signals from the baroreceptors in the carotids down the vagus nerve to the heart to slow a fast heart rate down. Obviously, we've been disconnected, so you can stimulate their carotid baroreceptors all day and nothing's going to happen. Patients with heart transplants must have a permanent placer, or maybe I should say may. They may need a permanent pacemaker placed, so as their body recovers and their heart rate is not adjusted yet to the body, the pacemaker can pace for that person and keep their cardiac output good, keep the heart rate up. There is a need for immune system suppression and transplant medications for life. This is, in fact, infection is a major cause of death, so we want to make sure that this person stays away from anybody who is sick if they can, and if they happen to have a fever, they need to seek treatment promptly because they are on immunosuppressant medication so they don't reject their donor heart, because you don't get those very often. Okay. What else would I like to say? Oh, yes. ICU monitoring. If you're the ICU nurse taking care of this patient, please watch out for new shortness of breath, maybe some bradycardia or even AFib and fluid gain. This may indicate that the body is rejecting the heart. I have one more point to close with. These patients need frequent angiograms on their heart. They need frequent angiograms on their heart. There is a condition called cardiovasculopathy. That's called cardiovasculopathy. And for whatever reason, the body still will not accept the heart 100% as its own. So over time, it will continue to place plaque and cholesterol deposits all inside the coronary artery veins and arteries. Actually, the arteries, excuse me. It will place it inside the coronary arteries. And our patients will actually be experiencing new coronary artery disease. They unfortunately don't have the vagus nerve connected, so if they start having chest pain from, say, in an area of ischemia or infarct, let me rephrase that. If they have an area of ischemia or infarct, they will not feel chest pain. So what do we do for this patient? We bring them in every 5 years or so and we do an angiogram and we squirt dye in the vessels to see if they are occluded or not, or if they need a stent or an angioplasty, or they open them up with a balloon, something to make sure that they are open and blood is flowing freely. So make sure your patient has frequent angiograms because this person is prone to develop coronary artery vasculopathy. This leads us to our next topic of discussing coronary artery disease. Now, next semester, you're going to get a full-on explanation of myocardial infarction and what you're going to do for it, but I have been assigned to teach stable angina or stable angina, however you want to say that. They say it both ways. So I'm going to give you a brief summary of the difference between an ischemia issue and an infarction issue, and if somebody has stable versus unstable angina and how you're going to fix it. So we're just going to barely discuss this condition. All right, definitions. Ischemia. Ischemia is insufficient oxygen supply to meet the requirements of the myocardium. There is no permanent damage that is done. And usually when somebody is experiencing ischemia, they start having chest pain. They just have some chest pain. Now, if, say, the person doesn't come to the hospital fast enough, or maybe the staff doesn't recognize maybe a female's presentation of ischemia, it can eventually lead to infarction. Infarction is necrosis or cell death that occurs with severe ischemia that is prolonged, and decreased perfusion causes irreversible damage to the tissue. We feel good about those? Difference between ischemia and infarction? All right. Now, I often ask my students, well, what causes somebody to have coronary artery disease? And I get a lot of different answers, but the main things we think about are hypertension, high cholesterol, maybe different toxins such as alcohol abuse, chemo, drugs, viruses and bacteria even can cause heart attacks, and even some like immune reactions, maybe such as like lupus. But in general, when we are looking at angina versus a real heart attack, if you can, just glance down the different signs and symptoms here. As you see, the acute coronary syndrome is much more extensive. But if we just focus on the angina part here, we're going to have substernal chest discomfort. Patients describe it as a squeezing sensation and chest heaviness. They may say that an elephant is sitting on their chest, but please notice that, if I can do my mouse here, we also have complaints of substernal chest pain with somebody who's having a real heart attack, ACS. And it's going to be radiating, but keep with me. I'll try to distinguish it for you. When we are having angina, it is usually precipitated by a time of exertion or stress. It's usually by exertion or stress. Really not so much rest. It is going to be relieved by nitroglycerin that you are going to give sublingually, and you're going to give up to 3 doses separated by 5 minutes. And remember what we need to check before giving nitro? Blood pressure. So make sure the person's blood pressure is greater than 100 because nitro will drop it. What side effect do we need to tell our patient to watch out for? And that it is an expected finding. Did you say headaches? Very good, because we're about to vasodilate all of the vessels inside the brain. Good. The difference about angina and ACS is this part right here. This is going to quit after 3 doses, and we are probably going to say this person has stable angina. If it does not stop and it continues to persist, we have a more serious situation on our hand, and this person will probably need to go to the cath lab stat. What's interesting enough about acute coronary syndrome, look what time of day it occurs. Isn't that interesting? And oftentimes, I mean, it can occur at any time of the day, but you will see a lot of heart attacks will occur in the morning time.
Very true.
See, that didn't take long, did it, to talk about stable angina? The big takeaways there are give them 3 nitros, assess their blood pressure prior to, and if it doesn't resolve in 15 minutes, call 911. There you go. And you're going to learn more about that next semester. But on to pacemakers and AICDs. So here you have the listed reasons why somebody is going to earn themselves an AICD. And if I have a patient in the hospital that has a low heart rate, I am going to try to assess why. I'm going to look at all of their medications, and I'm going to grab an ECG to confirm what is their underlying rhythm. This is going to let us know if we need to give them atropine, give them IV fluids, maybe oxygen, whatever the person needs. But let's just say we've identified no issue to reverse, and we've given them oxygen, and they are still, we've given them atropine, oxygen, IV fluids, and they are still bradycardic. Well, what are we going to do? In that moment, we are going to apply those pads that we place on patients to shock them, and we're going to do transcutaneous pacing. This is where the energy is going to be delivered transcutaneously through the thoracic musculature to the heart from those 2 electrode patches placed on the person's chest. Just FYI, it is very painful, and it is temporary and used only for emergency situations. So we oftentimes will sedate our patients for this because it is that uncomfortable. It's like touching an electric fence 60 times a second. Wow, that's a lot of times. 60 times a minute. It's a lot of touches, a lot of shock. So sedate your patient for this. Well, let's just say we were able to get our person to the cath lab, and we are going to take off those pads from the patient, and we are going to actually insert through their vein a little pacing wire. Is threaded through a central venous catheter, such as the subclavian, maybe the jugular or even cephalic veins, and they're going to lodge it into the wall of the right ventricle and also into the right atrium. And now we're going to have AV pacing, or atrial pacing and ventricular pacing. This is kind of cool, huh? They call these dual pacing systems. So that is called transvenous pacing, and this is done for a short term. A patient can maybe have this for a few days until they figure out, is this person going to, say, recover from the bradycardia, or do we actually need to go ahead and instill inside them a pacemaker? Okay, now if the person shows that they do not recover over a period of time, then we can actually insert that small little generator into their chest. They're going to feed those wires into their subclavian vein, and it's going to lodge into the sides of their heart. That is a permanent pacemaker. Those are usually changed every 10 years because the generator's battery will die. And one thing we should know about our person is, are they on-demand pacing or are they fixed pacing? Those are 2 modes that we need to know anytime our patient has a newly placed pacemaker, whether it's transvenous or the permanent one. Are they on-demand pacing, where that means it only kicks in if the heart rate drops below a certain threshold? Or is it fixed pacing, which means it just paces regardless what the patient's heart rate is? And when we actually are looking at a person's EKG, and once again, I know you are not trying to read EKGs, here's the normal PQRS cycle with a T wave. This right here is a pacer spike. It's small, skinny, narrow. This is how I know that my person has a pacemaker firing. I would probably like to explain what are the clinical manifestations of bradycardia. Everything you see here is perfusion related. Everything you see here. This is not unique to somebody with a low heart rate. If I have anemia, I'm going to have ineffective perfusion, and all of these signs and symptoms are probably going to be here too. Possibly. But Anyway, what would I like to, yeah, not much I want to say here. Okay. The nursing interventions that we want to implement for our patient are really summarized nicely in a table. I believe it's actually a chart, I should say, inside the chapter within your reading. So please make sure to visit that, and you will be able to do quite well on any question on the test that's regarding pacemakers. So just some basics. We're going to put our person in a sling, and we're going to limit their range of motion, particularly if they have their pacemaker right here. The last thing we want to do is dislodge the leads from the heart by having the person do too much movement. So they will probably wear this for a few weeks. In the immediate post-op setting, you are going to monitor the site for signs and symptoms of bleeding, redness, tenderness, an infection. I do anticipate it to bruise and to be very tender. However, there is a point where if the bruising is substantial, meaning it's down in the breast, it's over the shoulder, and there is a huge hematoma there, meaning it feels hard as a rock, I actually would probably want to notify the physician about that. Do make sure to report any signs or symptoms of cardiac tamponade. That basically will be decreased cardiac perfusion, and it's a very specific heart rhythm that you will see and learn next semester. They call that cardiac tamponade. We want to make sure our patient knows to report signs and symptoms of hiccups. Hiccups. What does hiccups have to do with anything? It actually means their leads have displaced from their heart, and they have actually attached themselves nicely to the diaphragm. That is pretty hard to do. However, I can imagine how painful that would be to have about 60 hiccups per minute. That would not be good. So tell your person to report hiccups. All right, the next day and for a few weeks afterward, the lovely nurse and tech are going to ask the patient to come in, and they're going to interrogate the pacemaker or the AICD. And what this means is they're going to lay this little device over the pacemaker, and it's actually going to transmit the data and to let us know if we need to keep the settings or if reprogramming is needed. So encourage the patient to, after they get out of the hospital, keep all interrogation appointments available, or keep their appointments. Last little bits of teaching here. Let's make sure our patient is aware that radios, cell phones, anti-theft devices, handheld security devices, car alternators could actually turn off or change a pacemaker's settings. I know, right? Now, there's actually a diagnostic test that a person with a pacemaker should never ever have this diagnostic test done to them. Do you know which one I'm talking about? That's right, an MRI. MRIs are made up of magnets, and we would actually be taking our patient into a situation where their pacemaker would be turned off. Now, I will say that technology has actually advanced, and I have seen MRI safe pacemakers come out. So I would like you to do this. Treat all patients with pacemakers as patients who should never have an MRI unless a patient produces a card, an ID card that actually says there is the MRI safe one. Okay, just to remember that. So they need to carry their ID at all times. If they are flying and traveling at the airport, they actually will set the alarm off. So they, not only that, they can have the machine that scans them change their settings. So they are going to not go through TSA. That I'm trying to think of what it's called. where they scan their body. They're just going to go through the pat down. They can only do the pat down. A patient needs to know what to do if a shock is going to be delivered. They actually need to go and sit down somewhere because it's going to take them a moment to catch their breath and recover. So if they're driving and they feel a shock, they need to pull over immediately. Sometimes they get a little dizzy from that process. Family needs to learn how to do CPR. They need to learn how to take a blood pressure, and they need to know how to take a pulse. This is extremely important for a patient or family member, to understand. Let's see. Also, during the recovery time, I know I kind of mentioned a few weeks, but our person needs to have exactly 8 weeks of restricted activity. They won't wear the sling for 8 weeks, but they don't need to resume normal life until after 2 months has passed. Please make sure they do not wear tight clothing or belts or purses over their pacemaker. It could actually erode away the skin and cause irritation there. Last but not least, if a person is near a device and they start feeling symptomatics of bradycardia, encourage them to move away. They need to basically understand that their generator is being turned off. So if they move away, it will stay on. All right, I am going to finish with a quick little personal story. This one patient I had at Sacred Heart, his AICD actually was misfiring, so it was actually delivering a shock inappropriately. And I've actually never had a patient that had the shock delivered right in front of me. So I was talking to him about his situation, and he was saying, yeah, I was working on my car, and next thing I know, I felt it kick. I was like, a kick, huh? He goes, yeah, it felt like a kick from a donkey right in my chest. And I was like, oh, okay. Well, I'm sorry to hear that. And next thing I know, he grabs his chest and says, ow! I was like, what? Oh my gosh, what? He goes, oh, it just fired again. I was like, really? And he's like, yeah. And I look at the monitor, and there it was. Actually, I could see where the defibrillator had discharged, and you can see the interruption of his rhythm, and then his heart basically restarted in that moment. It was only like a split second, so he didn't lose consciousness. And he was holding his chest. He's like, oh my God, that hurts so bad. It's like, oh, okay. And next thing you know, it happened again, like in that moment. Ow! And scared me to death, scared the family. And okay, so for the pacemaker or AICD to discharge in like that short a time, I went ahead and called the doctor, and he gave me permission to call the pacemaker, I keep saying pacemaker, the AICD rep, and that rep came up that night within a few hours and actually laid a magnet over the device, turned it off, as well as he interrogated it to see what was going wrong, and he programmed it to be off for the night. So I came in the next day to find out that that patient had actually done quite fine without his pacemaker on and AICD on. They took him to the cath lab and changed out the AICD, so he had a new one before he left the hospital. Question for you. What if I was actually touching him when it delivered the shock? Would I actually be shocked as well? Would I be shocked if I was touching that patient whenever it went off? Answer is yes, actually. I can feel a little bit of a shock. However, it is not enough to hurt or even to bother me. So patients will feel, or family members or whoever is touching the patient at the time of the shock will feel it, but it's not harmful. Does a AICD deliver a beeping sound or a warning sound before it emits a shock? Answer is no. That could make you a little bit crazy. That's what we do for like dog training. But if they cross the line or are barking too much, it will beep and then it will deliver the shock. That would be super bad. Okay, so AICDs or pacemakers do not deliver a beep. Okay, I hope everybody enjoyed this. If you have any questions, do let me know. And oh, one thing I get asked quite often, I'm sorry, I'll say this and I'll let you go. What's the difference between a pacemaker And in AICD, pacemakers only pace. AICDs shock lethal rhythms. Can an AICD pace? Sometimes. Some of them actually are made to pace as well, and sometimes they are only designed to deliver shock. So AICDs do both. Pacemakers only pace. How much does one cost? About $30,000 to $50,000. So we really try to do really good medical management before we actually place one in a patient because they are costly. Okay, that is it.